everyone. Today my topic is the role of gut in micronutrient malabsorption, in which we will see how the macronutrients and the micronutrients are absorbed in our body digestive system and how it plays a role in the digestion and the absorption phase. So coming to the basic definitions, micronutrients, these are essential vitamins and trace elements usually in small quantities in the physiological limit for continuing the physiological functions of the body. What is malabsorption? It is the impaired absorption of these nutrients, micro and macro, by the small intestine in general. How the gut will play a role. So central organ for digestion, absorption, immune surveillance of the body, and the microbiota interaction, and it will play a role in the dysbiosis and the absorption of these minerals. What is the significance of this topic? Why we need to have a discussion on this topic? Because it has preventable causes of morbidity and mortality throughout the world, and it emerges into the links of the chronic diseases, various chronic diseases, how osteoporosis, anemia, and cognitive decline happen in the body, and its role in global nutrition policies across the world and the clinical management of the malabsorption diseases. So coming to the mechanisms of absorption, which minerals are absorbed, how? There are two types of absorption, passive diffusion and active transport, and the third one is carrier mediated transport, in which vitamin D and E are absorbed by the body through the passive diffusion. Folate, iron and calcium are absorbed actively, and through the carrier mediated transport, the vitamin B complex vitamins are absorbed in the body. It requires an intrinsic factor for the carrier mediated transport. So coming to the etiology and classification of the diseases which are there for the absorption of the various minerals, it happens in three phases. First one is the luminal phase. So the luminal phase disorders in which there will be enzyme deficiency and specifically the bile salt insufficiency. In the second phase, it is the mucosal phase defects, in which the inflammation of the intestine will be there, villus atrophy, in which the villus of the intestine will become atrophy, and the transporter defects will be there, the digestive system transporters, which will be helpful in the absorption of these minerals, they will be having some structural defect, and post-mucosal abnormalities will be there in the third phase, in which we can commonly see the lymphatic obstruction and portal hypertension developing. Coming to the gut wall changes, what will be the changes in the wall of the gut? So first of all, villus atrophy will be there, reduced surface area will be there, the villus atrophy will be seen in the celiac disease, reduced surface area will be seen in short bowel syndrome, inflammatory disorder will be seen in the Crohn's and the colitis diseases. So coming to the absorption of the gut microbiota and the micronutrients. The microbiota mediated synthesis, this will happen through the vitamin K, biotin and folate. In this, the microbes in the body assist in the modulation of the absorption surfaces. Dysbiosis and malabsorption will take place in the second phase, in which the small intestinal bacterial overgrowth will take place, which is called as SIBO, which leads to vitamin B12 deficiency, and antibiotic associated dysbiosis will also take place when we intake antibiotics in excess, and AMR will lead, which will lead to the reduction in the synthesis of the microbiota derived vitamins. So coming to the nutritional deficiency disorders, which will be related to the gut microbiome malabsorption. First of all, we will be discussing about iron deficiency anemia. Second, hypocalcemia induced tetany. Megaloblastic anemia will be seen, and osteoporosis, which will be a systemic disease. Some extra-intestinal effects will also be there, in which there will be a cognitive decline in the vitamin B12 and the folate levels. Immunosuppression in the second phase, in which the zinc and the vitamin A levels will be significantly decreased, and the consequences of all this will lead to delayed wound healing in the various systemic diseases such as diabetes mellitus. So coming to the first one, that is the iron deficiency. So what are the common causes of iron deficiency? First of all, the celiac disease and the chronic blood loss due to various factors, geriatric surgery in general, hookworm infections will be there, which will causing in general the iron deficiency. The oral signs will be, first of all, the presence of angular cheilitis, atrophic glossitis, which is the smooth tongue without the papillae, and the burning mouth syndrome will be there, oral mucosal pallor, and the recurrent aphthous ulcers in the oral cavity will be there, which will have the increased risk for Plummer-Wilson syndrome, in which dysphagia and iron deficiency plus oral mucosal changes will be there. So how we will have the management of this oral manifestations? We have to have the complete blood count of the patient and include specifically the serum ferritin testing and the iron folate levels, in which will, if it is delayed, the invasive procedures will follow until first the anemia is corrected, and for the oral mucosal lesions, oral topical anesthetics specifically for burning mouth relief. Coming to the second deficiency, the vitamin B12 deficiency, common causes are pernicious anemia in general, the SIBO which I talked previously, the renal resection, and oral signs will be glossodynia, that is very painful tongue. Anything we will chew, it will have painful sensations. Beefy red tongue, oral mucosal ulcerations, burning sensation will be accompanied. Taste disturbances, specifically metallic taste will be there. Paresthesia of the tongue will be there, or numbness in the oral tissues will be present, and rarely it will develop into Hunter's glossitis, in which the tongue will become atrophic and very smooth, and the taste papillae will be reduced and vanished. So coming to the dental management tips for the vitamin B12 deficiency, refer for the serum vitamin B12 testing and avoid local anesthesia with vasoconstrictors in general if any neurological involvement is there, and coordinate with the general physician for parenteral B12 administration. Coming to the third deficiency, the folate deficiency, it will happen when there is increased alcoholic intake, celiac disease, pregnancy, and methotrexate use. Oral signs, painful ulcers, glossitis, gingival inflammation, which will be very common sign. Delayed wound healing, post extractions will be there. So coming to the dental management issues, educate on folate-rich diet, specifically in the pregnant woman. Supplement folate before any oral surgery, if at all it is there, and delay the elective periodontal surgery during deficiency. Once the deficiency is restored, we can go through the surgical procedures. Coming to the vitamin D and the calcium deficiency, common causes will be that fat malabsorption, which will lead to pancreatitis and the celiac disease, chronic kidney disease, oral signs, enamel hypoplasia will be seen in children, increased dental caries risk will be there, alveolar bone loss will be there, periodontal degenerative disease progression will be there, delayed tooth eruption can be there, and muscle cramps overall affecting the mastication in the TMJ area. So coming to the dental management tips, the use of the dental radiography for the alveolar bone levels, height, width should be used. Use of the fluoride and the remineralizing agents, toothpicks in caries bone patients. Collaborate with the endocrinologist for vitamin D therapy, specifically vitamin D3. And coming to the zinc deficiency, the zinc deficiency, in which common causes will be chronic diarrhea in general, liver diseases, acrodermatitis enterophagica, in which the delayed wound healing post-dental surgery will be the most common cause in zinc deficiency. Xerostomia, that is atrophic papillae on the tongue will be there for the oral manifestation, and the perioral dermatitis will be present throughout the oral cavity, and impaired taste sensation will be there. Coming to the zinc deficiency management, use of salivary substitutes, zinc lozenges or supplements for taste dysfunction, minimizing trauma during the dental surgical procedures. So coming to the last one, the vitamin A deficiency, common causes fat malabsorption, liver disease, impaired epithelial integrity of the oral mucosa will be there, xerostomia will be present, desquamatic gingivitis will be very common, and oral leukoplakia like regions which will be which is a very common cause. Coming to the dental management tips, prescribe topical vitamin A preparations, monitor for epithelial dysplasia diarrhea and the white fibrotic changes and the oral leukoplakia-like lesions, and address the oral dryness with lubricants and the wet mouth. So coming to the diagnostic approach, how these all diseases can be diagnosed. So through proper clinical history, first of all we have to see, because the gut is involved, so so the diarrhea, the sudden weight loss, fatigue issues and the neurological signs and symptoms should be approached through clinical history, dietary assessment and the intake of how the diet has been taken, what all are the micronutrients previously the patient has been taking, any supplementation if at all is there, we have to take care and play a role. Investigation first with the blood test, first coming to the CBC, specifically the serum ferritin levels, B12 levels, folate and the calcium should be evaluated because the gut is involved. So coming through the phases of the stool test, for the flat globules and the absorption of fat, we should take stool tests and reducing substances which will reduce the fat. Endoscopy with biopsy in advanced cases, so specifically for the villus atrophy, and the breath test for the SIBO, that is through the administration of hydrogen and methane, and the D-xylose test for the carbohydrate absorption should be taken for the diagnostic approach of the micronutrient malabsorption. Coming to the future research directions, already research is taking place in the gut-brain axis area, in which the micronutrient-linked neurocognitive disorders have been already explored. The genetic profiling of the transporter mutations, specifically the example of SLC19A2, that is a thiamine transporter in the digestive system, already studies have been going on. Microbiota dysmodulation using probiotics, prebiotics for the enhanced absorption has already been taking place for the research studies, and bioengineered supplements with higher bioavailability are being developed. So coming to the conclusion, what is the origin of this? So it has a multifactorial origin in which the micronutrient reabsorption requires an integrative diagnostic and approachive therapy for the proper approach to the gut micronutrient. And first of all, we have to target the mediator of the nutritional health. Emerging therapies may also allow personalized treatment and preventive strategies for controlling the role of the gut in the micronutrient malabsorption.